Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. Welcome to the show today, Professor Slavin.
Thank you. Thank you for having me.
Facial pain is a notoriously complex condition to treat. Can you walk us through why that is?
Facial pain is complicated. It's a condition that is both complex and difficult to treat for a variety of reasons. First of all, even though the face is a relatively small part of the human body, it is extremely well innervated. So face serves tremendous role in a person's life, not only as indicator of well-being and the way to express your emotions and help you to interact with other people around you, but houses remarkably important and to some extent vital elements: eyes, nose, ears. You have oral cavity with lips, teeth, and tongue. You have means of making facial expression, but you also use it for chewing and talking. All of these things inevitably add complexity to the contents of the face. And since it is so important in terms of movements and sensation, it has a lot of innervation. Whenever you have a lot of nerves, there's a lot of chance the nerves may not work properly. And therefore, it is not just to say that it's unusual to have a face pain. It's expected that every person at some point will have some kind of pain in the face. And that could be dental pain. It could be pain related to the nerves supplying the sensation to the face. It could be pain related to your eyes, to your nose, to your sinuses. And having all of this in a relatively compact part of the body makes it difficult to differentiate, makes it difficult to treat. In addition to that, the face has tremendously disproportionate representation within the brain and spinal cord. So the area that represents the face in the entire human body representation in the brain is larger than the same area for the leg or for the entire trunk. It's probably on par with your arm and hand. So by doing this, this happening, you know that there's a lot of cerebral components involved in sensation of the face, and therefore there's more chances for this to malfunction and create some pain. But this is a very long story, long introduction. But in general, facial pain is a complex thing because many things in the face can hurt. And the neurosurgeons or people doing neuromodulation tend to deal with issues of pain that have to do with dysfunction of the nervous system. So despite this high prevalence of facial pain, only few conditions in the face will ever require serious interventional or neurosurgical treatment. And that's kind of makes our job as specialists in this area to define the source of pain and then properly address it.
When you look at patient selection for neuromodulation versus other therapies, what are you considering?
The neuromodulation has been more or less a standard of treatment of variety of neurological conditions, including chronic pain. In the face, the use of neuromodulation tends to be limited to very few specific indications. There are multiple classifications of pain in the face. One of them tends to be more neurosurgical, one that specifically differentiates trigeminal neuralgia as a very common condition that presents with episodic, lancinating, sharp shooting pain in one of or several branches of trigeminal nerve versus other neuropathic pain conditions, post-traumatic pain from previous surgical interventions, pain due to other conditions like multiple sclerosis or the neuropathy of sorts or herpes infection. Those things tend to have very similar in location but different in nature pain conditions. And for neuromodulation, trigeminal neuralgia by itself, which is a very common condition, is not an indication. So when people talk about using neuromodulation for trigeminal neuralgia, they are unfortunately wrong. There's no use of trigeminal neuralgia, no use of neuromodulation treatment of trigeminal neuralgia. All other kinds of pain, on the other hand, are very good indications for neuromodulation. So when we talk about trigeminal neuropathic pain, or the condition that's called trigeminal deafferentation pain, meaning that the pain that occurred after surgery that ended up cutting the nerves one way or another those type of pains do respond to neuromodulation. So pain after shingles or herpes infection, the pain after strokes, like neurological dysfunction of the brain, pain after trauma, injury of any kind, including surgery on the eyes, sinuses, facial tissues, those are good indications for neuromodulation. And by virtue of being so complex, the pain transmission system that involves the trigeminal nerve, the ganglion, the trigeminal nucleus, the brain itself, there are many targets for neuromodulation. So that makes this area of neuromodulation particularly fascinating because you have multiple conditions, you have multiple procedures, and our job is essentially to match each condition with the right treatment. So we created an algorithm for this many years ago, and we continue using this for our patients. That algorithm includes neuromodulation and other interventions. But in essence, it starts with making correct diagnosis, choosing the right modality, trying it for the patient, and then using it as long as it works, or moving on with something else if needed. So that's kind of escalation of complexity, escalation of invasiveness, but at the same time, trying to minimize side effects, minimize negative consequences, minimize the invasiveness, trying to give the maximum relief at the least cost to the patient. And when I talk about cost, I'm talking about the risk of medical or surgical complications.
The algorithm that you mentioned, can you speak to how that was developed and the level of efficacy that it has?
Of course. The algorithm that we came up with was first published almost 20 years ago. The idea behind it was essentially related to the complexity of the condition. When you have pain in the same area of the body, in this case, pain in the face, that could be described or classified into 20 different, very distinct conditions, makes it more challenging to choose the right procedure. At the same time, there's at least 10 different interventions that people use for treatment of facial pain. So to match them in the right sequence, the idea of algorithm was introduced. And the purpose of the algorithm, not only to match right patient with right intervention, but also to streamline the decision-making process. Because for established practitioners like myself, or for people who are just starting their practice, it may not necessarily be very obvious why this or that procedure is being chosen for each particular patient. When you have an algorithm, particularly published algorithm, where things are more or less streamlined with arrows and signs and so forth, then things start making more sense. When you start with first step, you go to the next one, and then based on yes, no decision, you move on. And when you have so many conditions and so many treatments, it makes sense to put them in the shape of algorithms so that you can have a line of thinking behind each decision-making step. So when you have these arrows or other signs moving from one step to another, answering yes or no to each particular question, then you create more or less path of decision-making that makes sense. So instead of saying, well, let's try this procedure for this patient and see if it works, you have a very regimented approach saying that for this condition, this works the best. Therefore, it should be tried first. And if it doesn't, the contingency plan will lead you to the next intervention, which will be perhaps more invasive or maybe less predictable and so forth. And moving on to the most extreme areas, most extreme interventions, which are reserved for most intractable patients, hopefully never needed at this point. But if you start from the wrong procedure to begin with, then the chances of it not working become quite high. So you really want to make sure that the right interventions are reserved for right indications.
And I would say many listeners are going to be familiar with spinal cord stimulation for back pain, for example, but facial pain might be a bit of a surprise. Can you speak more about it and just give us an understanding of the landscape and the technology that's used?
Absolutely. The facial pain can be addressed with a variety of interventions, including neuromodulation. And when we talk about neuromodulation, the facial pain tends to be associated with use of the what's called trigeminal nerve stimulation or stimulation of the branches of trigeminal nerve in the face. This falls under the realm of peripheral nerve stimulation when we stimulate either supraorbital nerve that tends to be above the eyebrow or infraorbital nerve that goes under the eye or the mandibular nerve that travels in the bottom of the face. That's more of the peripheral stimulation. But if you move more centrally, you can stimulate the ganglion of trigeminal nerve. And the next step will actually be spinal cord stimulation, which is kind of surprising because spinal cord and face are not really connected from the layman's perspective. Now, it turns out that the trigeminal nerve, the nerve that supplies sensation to the face, has one of its main nuclei, the nucleus, the principal nucleus of trigeminal nerve, is located in the spinal cord, in the uppermost part of the spinal cord, coming from this evolutionary theory that, the face is just a continuation of the neck, and The earlier order animals will have all sensory neurons in the spinal cord. So the representation of the trigeminal nerve in the spinal cord correlates with the level of the neck or the back of the head, and that's where trigeminal nucleus is located. So by stimulating uppermost part of the spinal cord, we can actually catch the area of the face with our stimulation, and especially the outer aspects of the face. And therefore, we use spinal cord stimulation for facial pain, especially for those cases when peripheral nerve stimulation is not effective. And then after that, the next target for intervention will be even more central structures, meaning the deep brain nuclei, the motor cortex of the brain, something that rarely, if ever, needed, but those are kind of next steps if the less invasive interventions fail.
Have you observed specific interventions that are your go-tos, that are the most successful or maybe the lowest risk profile, so you start with them most readily?
Absolutely. As a matter of fact, the most commonly used interventions for facial pain do not involve neuromodulation. So, for example, for patients with trigeminal neuralgia, our procedure of choice is called microvascular decompression. That's an open surgery that finds the trigeminal nerve root and relieves pressure, which is caused by adjacent blood vessel. So we'll find this area where the vessel compresses the nerve, we separate them, we put some Teflon padding to prevent further compression, and that tends to eliminate the pain completely. If the patient, for whatever reason, cannot have microvascular decompression, then we still don't use neuromodulation. We use what's called destructive surgery. So we either do percutaneous destructions when we insert the needle in the patient's face, find the nerve, and destroy the nerve either with electricity, through thermal damage, heating it to a certain temperature, or injecting some chemicals like glycerol, or using a balloon compression procedure, which literally crushes the nerve and ganglion. Or there's also option of stereotactic radiosurgery, which is done by devices like Gamma Knife or CyberKnife, and those are focusing the nerve with specific purpose of destroying the nerve fibers that are responsible for pain transmission. So those are not neuromodulation procedures, and they are reserved for treatment of trigeminal neuralgia. Non-trigeminal neuralgia patients with facial pain, like patients with trigeminal neuropathic pain or deafferentation pain or postherpetic pain, those patients would not benefit from the interventions that we use for trigeminal neuralgia. And that leaves us to either something that will cut the nerve, which is something we try to avoid, or use neuromodulation devices. And that's, interestingly enough, was used even before spinal cord stimulation was invented. It's very interesting because if you look at the history of neuromodulation, the theory behind it, it's called gate control theory, that postulates that you can control pain by producing non-painful stimulation, was introduced in 1965. And the first way to illustrate this, the neuroscientists decided to try it in a series of patients with neuropathic pains, and they used peripheral nerve stimulation on them. But in order to test it on patients, they tested on themselves. So these two researchers literally put electrodes into the face of each other, trying to stimulate infraorbital nerve. And while stimulating with electricity, they were able to suppress the pain. It's very fascinating and completely unimaginable these days experiment that people did on themselves. We don't condone doing this, but we talk about this because that was an example of scientific spirit of those days. And so stimulating nerves in the face, they were able to document effectiveness of electrical stimulation, and that became essentially prototype or predecessor of clinical use of these devices. And then soon thereafter, the spinal cord stimulation was introduced. And within a few months, another paper came out which showed that people were actually trying neuromodulation with high-frequency stimulation of trigeminal nerve even before gate control theory was postulated. So the first clinical use of peripheral nerve stimulation for treatment of facial pain dates back to 1962, which is more than 60 years ago. And ever since that time, the neuromodulation has been used sporadically here and there for very specific circumstances. It has become more of the mainstream in late 1990s and early 2000s. And we were one of the first ones to use it. And ever since that time, it has become widely accepted. So when people talk about neuromodulation for facial pain, they summarize all of these approaches together. And in those patients who are good candidates for intervention, this type of approach is remarkably effective. The pain responds to this. The patients love stimulation. And I have patients who I personally treated more than 20 years ago who continues to enjoy pain relief with appropriate neuromodulation. So I'm very proud of this. And In addition to that, we do have patients with cortical stimulation, spinal cord stimulation, that have also been using it for decades. And therefore, the use of neuromodulation in facial pain is considered more or less standard for very specific indications.
The story that you shared about the researchers reminds me of the phrase of not doing unto others as you would do upon yourself. It brings new meaning to that phrase. Can you speak a little bit more about gate control theory for those who aren't aware?
Of course. Now, the example of self-experimentation is something that, interestingly enough, was popular back in the day, way before the scientific methods were conceptualized. But we don't do it now. Thankfully, we have some other models where we can test our new modalities and approaches. But back then, I think that was a very convincing way to show that the modality is indeed safe. But the gate control theory of pain was postulated by neuroscientists Melzack and Wall. They came to the conclusion, based on a series of experiments, that the air is a part of the nervous system that serves as a gate control mechanism. Essentially, they postulated that there are some neurons within this pain transmitting pathway that not only transmit information about pain, but they also are involved in transmission non-painful information. So somewhere along the course of the pain path, there is a relay that can transmit both painful and non-painful information. And if you flood that element with non-painful information, then pain will not go through. So this gate control will essentially lock the gate, and there will be no path for the pain signals. So the illustration of that, the peripheral nerve stimulation and then the spinal cord stimulation, essentially allows person to feel non-painful sensation, which they describe as pins and needles or the hand scrolling or something that medically is called paresthesias. That's not a painful sensation. It's more like light touch sensation. So if we can elicit paresthesias in the area of pain, then most likely the pain sensation will subside. And that's what we see when we use conventional spinal cord stimulation. So conventional spinal cord stimulation is based on paresthesia production. So when we stimulate certain part of the spinal cord, we create the sensation of paresthesias. And as long as we can put it in the area that normally hurts, most likely the patient will feel improvement in his or her pain. So that's what's called concordant paresthesia. That's called the correlation between the location of paresthesias and the pain relief. And that's why the trials for spinal cord stimulation are usually done with a person being awake, because we want to map the location of that sensation. When we test the patient on a table, we turn the stimulator on and we try to switch between different contacts until the patient describes that the area where they normally hurt is covered with stimulation. If we don't get this concordant coverage, the chance of getting pain relief becomes significantly lower. So when patients are inquiring, why do I need to be awake during the testing? It's for that very reason. We want to make sure that the areas of pain are indeed covered with stimulation. As a matter of fact, when I do stimulation on my patients, I ask them only 3 questions. I ask them to tell me when they start feeling the stimulation, kind of yes and no type of issue. The second question is where they feel it. And we want the patient to describe the location, be that the foot, the leg, the lower back, the arm, depending what we're trying to stimulate. And then the last question is whether or not their areas of pain are fully covered. And if the patient tells me that most of it is covered, but some part is not, then I will continue testing until everything that normally hurts is covered with stimulation. Only then I would consider location of electrode adequate. And after that, the patient will be able to test this modality, usually for up to a week, to see if it actually helps them with pain. So that's what neuromodulation trial usually consists of. There are certain modalities that do not require paresthesias. The more modern approach to spinal cord stimulation is not based on gate control theory of pain anymore. There are some other mechanisms that are somewhat more complex. And for those, we do not need concordant paresthesias. So if your doctor tells you that they will not be testing you on the table and will put electrodes solely based on x-rays, most likely they will be using some other paradigms of stimulation. But the conventional stimulation, something which used to be the only option back in the day, requires testing. And that's the reason why most patients will still need to be awake during the testing stage.
Okay. Is motor cortex stimulation utilized for facial pain?
It is. The motor cortex stimulation is a very unique modality because, as opposed to everything else we do in neuromodulation, which focuses on sensory pathways, the motor cortex stimulation literally stimulates motor cortex. motor cortex is a part of the brain that's responsible for movements. So it's something that moves your arm, your face, your leg, depending which part of cortex we're talking about. And for central pain, the pain that stems from disruptions at the cerebral level, the motor cortex stimulation seems to be an excellent option. So for facial pain, we use motor cortex stimulation, at least in my practice, when the patients are completely numb. So when they have no normal sensation because of the previous surgeries, then trying stimulation at the periphery, be that on the face or in the ganglion, is destined to fail because we cannot elicit paresthesias. The numbness means that the information does not reach the brain from the periphery, and that's why peripheral stimulation is not an option. The central stimulation, on the other hand, is an option because central pathways that exist in our brains, they are still there, and there is intrinsic ways to control the pain that are able to suppress pain perception. And it turns out that stimulating the motor cortex allows us to suppress the pain. How it works exactly, nobody really knows, but there are certain assumptions or certain hypotheses to explain this, and they have to do with either cortical inhibition, meaning stimulation of one part of the cortex inhibits the other one that's responsible for pain perception, or there's corticothalamic inhibition that we're stimulating the cortex and we're trying to inhibit thalamus, which relays the pain processing. There are several other concepts that are probably just as valid. But in principle, with motor cortex stimulation, our goal is to find representation of the painful spot in the cortex and then put stimulator onto that spot. We don't go into the brain for motor cortex stimulation. We're staying outside of brain, but that usually requires craniotomy. It means we need to open the skull so we can slide the electrodes over the brain surface and keep it there for the stimulation. People talk about different screening tests, and one of the possible screening tests is what's called transcranial magnetic stimulation, and that's a non-invasive way to stimulate motor cortex. This unfortunately doesn't predict long-term effect of motor cortex stimulation, but it could be used as a screening test in principle. So there were some well-designed studies that showed the value of transcranial magnetic stimulation as a predictor of success. But even now, we don't routinely use this approach because every patient is slightly different, and we make decisions about surgery exclusively based on the patient's pain patterns, the neurological examination, and perhaps on imaging findings.
So we've got spinal cord stimulation, SCS, peripheral nerve stimulation, PNS, motor cortex stimulation, MCS. Are there any others that are notable in the field that are worth mentioning?
Yes, there are two other modalities that people talk about, actually three other modalities. One is called deep brain stimulation. That stimulates either thalamus or some other parts of the brain that are responsible for pain perception. Tends to be somewhat more invasive because it requires insertion of electrodes into the brain. There's also something that's called GGS, or Gasserian ganglion stimulation. That stimulates the trigeminal ganglion, which is located inside the head, kind of under the brain. And in order to get there, we really need to reach it with special instruments. It's rarely done because it is hard to secure electrode in that location. But there are some well-documented papers using this modality for, once again, very selected patients. And then the third way to reach the facial pain is to stimulate occipital nerves. Now, the occipital nerves are not cranial nerves. They are coming from the neck, and they are located in the back of the head. They literally supply the occipital part of the head. But by stimulating occipital nerves, we can have suppression of facial pain because occipital nerves and trigeminal nerves are the ones who supply the face. They have common representation within the spinal cord. It's called trigeminal cervical complex, and by stimulating occipital nerves, we can control some specific cases of facial pain, especially in case of cluster headaches or similar autonomic phenomena, when occipital nerve stimulation will suppress the pain, even if it occurs in the face itself. So occipital nerve stimulation is like a stepping stone to more invasive interventions, and it's used for very specific indications. So that makes 6 different targets: the trigeminal nerve and its branches, trigeminal ganglion, the occipital nerve, the spinal cord, the deep brain nuclei, and the motor cortex. But to make things even more complex, there is yet another ganglion that can be stimulated for facial pain, and that's called sphenopalatine ganglion. That happens to be in the depth of the face, and as opposed to trigeminal ganglion, which supplies somatic sensation, the sphenopalatine ganglion is a part of autonomic nervous system. that's involved in tearing or nasal congestion or the size of the vessels, so vasodilatation of the face, those are controlled by sphenopalatine ganglion. So patients with autonomic facial pains or headaches, cluster headaches, hemicrania continua, several other conditions, they tend to respond to us blocking the sphenopalatine ganglion. So when people inject local anesthetic or even Botox trying to control that ganglion, that's what they address. And several years ago, we had a very dedicated device specifically for sphenopalatine ganglion stimulation. It's not available anymore because of some issues with the company that was making it, but the concept is still around. So we do use sphenopalatine ganglion stimulation every now and then, either as a standalone modality or as an adjunct being used together with trigeminal or occipital stimulation. We recently published one of the cases when it was remarkably successful, but I got to tell you that it doesn't work every time. There were plenty of cases when it didn't work, and the only reason we even consider it is because it's generally safe intervention, and if it works, obviously everybody's happy, but if it doesn't, I feel that it may be less risky than some other stuff that we do.
This lends me to wonder about what some of the challenges are with optimizing the parameters for stimulation for facial pain. Can you speak more to that? And feel welcome to focus on whichever of the techniques is most relevant to the conversation.
Of course. And this is always an issue because just like every patient is different in terms of the pattern of their pain and location of pain, the same holds true about the patient's response to stimulation. So what that means is that the parameters that would work for one patient may not necessarily be as effective for another one. So we have to create those parameters individually, and that's why interaction with patient becomes remarkably important. We want to make sure that the patient feels pleasant sensation, that what we do with our adjustments of parameters does not cause unpleasant phenomena, be that worsening of pain or worsening of numbness or anything that will create negative response. So we want to make sure that the stimulation we use is well perceived and tolerated by the patients. And then we want to see how effective it is, because for certain types of pain, lower frequency stimulation tends to be more effective. For others, it will be higher frequency. But ultimately, there's a certain range of parameters that we use. And then within that range, we adjust the settings based on the patient's individual response. There's no cookbook for this. The adjustments are done in real life, in real time type of regimen. So when we bring the patient to clinic, adjust the parameters, watch patient's response, and then make more adjustments if needed. So when patients come for programming sessions, we encourage them to stay around for an hour or two so we can go through different setups and make sure that the patients are comfortable with the result of it. Some of the stimulation is not actually felt by patients. So when we talk about motor cortex stimulation, there is no paresthesia, there is no elicited response. So we end up changing things and literally observing the patient to see if our adjustments made a difference in terms of suppression of pain. If things work well, the patient will see some improvement within a few minutes or maybe within an hour. If it doesn't, then we can do more adjustments, either increasing, decreasing, changing the pattern of stimulation, and so forth.
Thinking back on the algorithm your team developed, as well as we have another episode of the show this season that is featuring Dr. Erica Peterson, where she talks about big data and AI tuning to sort of influence how we perhaps start with parameters. Do you think that facial pain is something that will fall under that umbrella, or is it too specialized?
I definitely hope so. I really need some help, and AI will be something that I would be counting on for the eventual streamlining of the adjustment process. Right now, it will be somewhat challenging because of relative rarity of these interventions. We do not use neuromodulation for facial pain very often, which is probably a good thing. Majority of patients with facial pain would not need neuromodulation. They will be perfectly fine with either medications or some non-surgical treatments. And if there are some surgeries, there may be some non-neuromodulation modalities which will produce complete cure of their painful syndromes. For those patients who do require neuromodulation, we try to summarize our data, we try to publish our results, and so do our colleagues. But there are no large series in that regard. So one day there will be some way to summarize material from different centers, perhaps through either prospective registry of sorts or just by a large multi-center data collection efforts. And once this is available, then I would definitely expect AI or some other technology at that time that will process the data and come up with some automated algorithm.
Do we have any biomarkers presently that indicate whether or not a patient is likely to be a successful candidate for neuromodulation for facial pain?
Not yet. Not yet. We do not have those markers yet. We talk about different things that may be eventually considered as such markers. We usually rely on either imaging data or some biochemical elements or tests, but so far I'm not aware of them. So there are some predictors of success for non-neuromodulation treatments. So when we have compression of the nerve with blood vessel, then more or less we can predict success of the microvascular decompression, the surgery to treat trigeminal neuralgia. For neuropathic facial pains, I'm not aware of the existence of such markers.
Okay. And closed loop systems are making pretty notable waves in movement disorders, spinal pain. Do you see application in the facial pain space?
Yes. Eventually, I would expect the closed loop stimulation to work through very similar mechanism as it does with spinal cord stimulation. For us to be able to record response of the spinal cord to the stimulation and adjust parameters based on this response is a very appealing concept. It's somewhat more challenging when we deal with facial pain because the transmission distances are somewhat shorter and there's not that much room for recording. But I think that's just a question of time. There will be some devices that will allow us to record responses to our stimulation. And once this happens, I would expect the closed loop approach to be used here as well.
Makes sense.
Everything we've talked about today had to do with electrical neuromodulation, which is, as you know, the hallmark or the main neuromodulation approach these days. The other way to modulate nervous system is through the use of chemicals. The chemical neuromodulation on the most basic level will include some oral medications that you take just to calm down the nerves. In more surgical way, the neuromodulation with chemicals involves implantation of intrathecal pumps, something that delivers medication into the spinal fluid and modulates neural activity through these medications. When we talk about use of baclofen for treatment of spasticity, use of morphine or zacronitide for treatment of pain, those are examples of electrical neuromodulation. So as such, we can be used for treatment of facial pain as well, but it is somewhat more challenging because the centers that are responsible for processing of facial pain are located either in the brain itself or right next to the brain. So whatever we deliver to those areas will carry significantly higher risk of having complications. And that's why the chemical neuromodulation has been only rarely used for treatment of facial pain. The unique category when this is used more frequent has to do with facial pain due to cancer. When people with oncological conditions, with all kinds of cancers involving area of the face present with severe pain, we do not hesitate to use intrathecal drug delivery, and in that case, we may consider it even early on in the course of treatment because the cancer pain tends to be even more complex, involving both nociceptive and neuropathic components when there's some tissue damage, where there's nerve damage on top of this. So for those patients, we are somewhat more aggressive in terms of choice of modalities, and intrathecal drug delivery may definitely be an option. And then when we talk about future of neuromodulation, we talk about use of new kind of out-of-box thinking involving optogenetics, low fidelity, low power ultrasound. We talk about the use of pulse radio frequency or some other interventions on very high or very low frequency electricity that, or even radiation of sorts that produces reversible effects. So right now, I'm not aware of any of them being used for facial pain, but I remain optimistic because as the field matures and there's new approaches and new modalities being introduced, some of them will be used for facial pain treatment. And I definitely feel that at some point we will have a solution pretty much for every patient that comes to us with this condition. And the concept of untreatable or incurable pain will just disappear.
Both thinking on cancer pain as well as out-of-the-box treatments, I'm curious, do you see intersections already or into the future around regenerative medicine, neuroimmune modulation, psychedelic therapy, and bioplasmic neuromodulation? These are some that I'm seeing come up in the news.
Yes, and those things definitely attract attention of our patients, and they have these questions when they come to see me. What I can say with a high degree of certainty that none of these treatments have so far shown established effectiveness for treatment of facial pain. So I would somewhat discourage patients for trying untested or unproven approaches. I'm optimistic about future. I think there will be something along the line of either immunomodulation or use of some out-of-box drug approaches, which will be particularly helpful for this. But currently, from everything that you mentioned and pretty much everything else, none works all the time and none is specifically designed or intended for treatment of facial pain. So I'm aware of all these initiatives. I know that there's some research happening in those directions. And once something becomes effective, I will be more than happy to offer it to my patients.
Is there anything that you've come across in your career that really surprises you in facial pain?
Yes, indeed. The most surprising thing about facial pain is not only its high prevalence, the facial pain is probably as prevalent as a back pain, but also the fact that most patients with facial pain are not typical chronic pain patients. They are very happy people in many ways between painful attacks. This is particularly true about patients with trigeminal neuralgia, which is debilitating, painful condition, but still does not make the patient into chronic pain sufferer, because between painful attacks, the patient may end up being completely pain-free and they maintain very healthy psychosocial profile. The patients with chronic pain in other body parts, they tend to be much more disabled because of this. So the trigeminal neuralgia is rather an exception to the rule, and therefore by eliminating the source of pain, doing microvascular decompression or numbing up the face in order to control the pain, usually returns these patients back to completely normal quality of life, which is something that we may only aspire for when we treat other painful conditions.
Have you observed any trends in psychosomatic alignment with facial pain?
Absolutely. The way to deal with pain does not remain limited to use of medications or surgeries. To learn coping with pain, learn living with pain is remarkably important. So patients who are able to manage the pain through conscious coping approaches, including meditation and ability to distract yourself, or having them social interactions that will allow them to, I don't want to say ignore, but at least not to be focused on pain, that tends to be tremendously useful. The psychological component of pain is extremely important. And when it comes to facial pain, even more so, because the face is there all the time. People look in the mirror, they see the suffering part of the body. And that's what makes the psychological component of pain so important.
What are the most common comorbidities for facial pain?
Majority of patients with facial pain will not have any directly related comorbidities. The exception to that will be demyelination, something that is frequently described as multiple sclerosis, when people have facial pain as a part of larger neurological syndrome. So those patients will have often other neurological symptoms, not just the facial pain. And the facial pain that they have may not necessarily be predictably responsive to conventional treatments. It doesn't mean that we cannot treat them. As a matter of fact, we can treat them quite well with established surgical interventions, not neuromodulation, but other ones. And the key part here is not to make pain frustrate you. So if you do have pain and you do have a diagnosis of multiple sclerosis, seek medical attention. There's very good chance that your pain will be completely eliminated and you will be able to return to more or less normal quality of life.
So say a listener is a general practitioner or perhaps a patient themselves, do you have any first stops or recommendations? Facial pain is onset now. What would you recommend as a starting point?
The starting point for the patient would be to seek medical help. Don't ignore your pain. Don't let it progress to the point that it will become refractory or intractable. The first stop for most patients will be their dentist, who very often is able to differentiate between the dental sources of pain, be that bad tooth or abscess of sorts, or the nerve responsible for it. And once the dentist or primary practitioner identifies the nerve as a possible source of the pain, they would normally refer the patient to a neurologist or directly to a neurosurgeon, and those doctors will help with confirming the diagnosis and offering proper treatments. To seeing a pain specialist for pain that affects the face or other parts of the body, including face, will also make sense. The pain specialists are perfectly capable in making diagnosis of both trigeminal neuralgia and trigeminal neuropathic pain, and then they can decide if there's something that they can offer will be helpful to the patient, or if the patient needs to be referred to a neurosurgeon. The neuromodulation, being remarkably effective for certain neuropathic pain conditions, is reserved for a very specific category of facial pain patients. And if that turns out to be the best modality or modality of choice, then seeking an expert or somebody who specializes in this, or at least has sufficient experience to comfortably deal with this, will be probably the most important step. By dealing with this for so many years, we have established more or less, I don't want to say center of excellence, but center that attracts patients with complex facial pain. We've seen all kinds of it. And when we published our algorithm, it was a result of years of experience dealing with large volume of facial pain patients. And that served as an indicator of our seriousness about this, our scientific and research interest in facial pain. And as a result, we started seeing even more patients coming to us with that. And therefore, it kind of makes sense for the patients to find a specialist who will be interested in helping them. I feel like matching the patient with the right doctor or right team is probably the most important step in the treatment.
And for those who do end up utilizing neuromodulation as a pathway to address neuropathic pain, what level of efficacy are we seeing? How many people are having positive outcomes?
The positive outcomes in neuromodulation is observed in vast majority of patients. I don't want to say 100% because nothing is ever 100%, but very high number of patients will obtain an improvement. Now, the degree of improvement varies. Obviously, we want to have 100% pain relief, the pain to go away completely. And interestingly enough, in the realm of facial pain, that happens quite often. If the patient is using proper modality for pain control, there's a good chance that his or her pain will be gone as a result of neuromodulation. Doesn't happen all the time. There will be patients whose pain is improved only partially. But you got to keep in mind that even partial relief is better than no relief. And the best way to confirm this is to turn the stimulator off. When the stimulator dies because of the battery depletion or just get turned off by the patient, the return of pain immediately allows them to understand how much stimulation actually helps them. So some people do it intentionally just to confirm that the modality works for them. Some people do it accidentally. They lose their charger or forget to recharge their device, or they let their generator to become fully depleted. And then the return of pain pushes them up almost to a level of emergency because they need to have device recharged, reprogrammed, replaced in order to regain the benefits. So the good thing about neuromodulation is obviously its reversibility, its adjustability, its testability. The bad thing is that it has to be remembered. It's something that would not work if the battery is not properly charged. I tell my patients about filling up the tank in their car. If they run out of gas, they will need to go to the gas station to fill it back up. It's the same thing with electrical devices. If they run out of juice, either the battery will need to be recharged if it is a rechargeable device, or it will need to be replaced with a new battery if it's not a rechargeable device. So keeping an eye on this, talking to your doctors, making arrangements for device replacements when it is due is something that we strongly recommend.
But something that I'm hearing is that neuromodulation is far down the line in the path of treatments for facial pain. And then once someone gets there, it's still a high degree of hope. So in general, facial pain sounds like something that is very impactful to somebody's life, negatively impactful, but there's a lot of hope for recovery. And would you say also restoration of sensation?
Those are very different things. The patients whose sensation is lost may or may not experience improvement, but unfortunately, neuromodulation, the way it is today, is not involved in restoration of function. So if their sensation returns, so the better. But the goal of our treatment is simply to control the pain. So our goal is to make the patient as functional and as comfortable as possible. And thankfully, neuromodulation allows us to achieve that. In terms of restoration of sensation, that's a somewhat different story. And I'm not aware of any neuromodulation techniques that would improve the sensation just yet. So whenever it becomes available, I'm sure the patients will be first ones to learn about this, as the doctors will be eager to help them.
More to come.
Absolutely.
Is there anything that we didn't cover today that you'd like to highlight before we close?
I'm sure there's many things I'm forgetting, but right now I feel that we provided rather comprehensive overview of the neuromodulation for facial pain. So I hope the patients will learn something from this, the doctors will learn something from this. And just to wrap it up, I want to say that me and my colleagues are always available to talk about this. So I think the worst mistake the patient can make is to hesitate to discuss conditions and treatments with his or her doctors. So when you see your physicians, if you are concerned that some modality will be of benefit to you, do not hesitate to bring it up. If the doctor agrees with you, then they will start this treatment for you. If they don't, they will probably explain you why they don't agree with this. So don't hesitate to bring up your ideas and pay attention to what the doctors tell you to explain their view on these things. You can't underestimate the role of specialists in picking up right diagnosis and offering proper treatments. But at the same time, the patients need to be aware of which specialist to see. So to see their primary doctor, their primary healthcare practitioner, that should be the first step for them. Because our colleagues who do primary care will be able to know or determine which referral is the best suited for this particular patient problem.
Excellent. Well, we also will link to your book on facial pain in the show notes, as well as the plethora of research that you've contributed to the field. So for people that want to learn more, they can look to those resources. And with that, I want to thank you for being on the show today. It was great to have you.
Thank you for speaking with me about this.